Good morning, friends. We'll start our discussion and Dr. Narula will join us soon. Madam, I'll start with the first case.
Yeah, please do.
We have a 10-year-old male child who was born of second birth order, full-term normal delivery, whose birth weight was 3.4 kg, had normal milestones, growth and development. He had no major illness in the first 6 years, except as per the history given by the parents that he had few episodes of fever for which he had taken some treatment from his doctor, including antibiotics on a few occasions. He has one documented infection in form of fever and diarrhea, where CBC was reported to be normal. His stool examination showed pus cells, mucus was plus, and urine showed 10 to 15 pus cells. There is no report of any urine culture or ultrasound at that time. He was given norfloxacillin for 5 days. Now he presents to us at 10 years of age with high fever with chills for 3 days, pain in abdomen and left lumbar region. His urine routine showed 30 to 35 pus cells, bacteria plus plus, protein 1 plus, and urine culture showed E. coli 10⁵ colony count. And he was treated for 12 days. So ma'am, can you tell us whether this would fit into our definition of recurrent UTI and why are we so worried about recurrent UTI?
In our country, it's always believed that when you do the urine culture for the first time, it is the first UTI, but it's never like that. For example, in this child, umpteen number of times the child had fever without a focus of infection, given some antibiotics for 3 to 4 days, without any urine culture, and hence there is no way to say that this was the first UTI at the age of 10 years. Probably there were multiple urinary tract infections, but this is of course very difficult to say. The other thing is, at the age of 6 years, he had an episode of fever with diarrhea and urine showing 10 to 15 pus cells. The dictum for the urinary tract infection, pus cells more than 5 at any time, should be followed with culture. And that is the definition of UTI. I've been doing these UTI sessions for the last 3 turns in this panel. Every time I have to tell something different. And last time, if any one of you who have attended, I have very clearly mentioned how to diagnose the UTI. So culture is a must. The second thing I would like to mention in this, if culture was done and if it was positive, this boy should have undergone ultrasonography at that level. We will learn about it, how important it was as you go ahead with the...
Why are we so worried about recurrent UTI? One UTI, second UTI, it should be the same, isn't it?
Yeah.
So why are we so much worried about it?
With every increasing attack of UTI, there is a risk to the kidney which increases. And whether the underlying pathology is obstructive uropathy or a vesico-ureteral reflux, wherein you find now the mandate goes on the pediatricians. With this forum, with the pediatricians, I would like to mention, don't forget your clinical acumen, don't forget the physical examination. All neonatologists should document whether the urine was passed by a male child first day in a good stream. All of them should palpate the abdomen of the child, whether it's a male or a female, and if you find any time renal lump or a distended bladder, this child should undergo ultrasonography, especially if the antenatal ultrasonography has shown some abnormality. So these are the clinical clues, and these are very simple. If you miss this, you miss the bus, and the baby may go into recurrent urinary tract infections and may result in bilateral scars. If there are bilateral scars and repeated UTI giving repeated scars, there is a chance, it's not such a big major, sort of a percentage. The child may go into chronic renal insufficiency, rarely going into end-stage renal disease, but definitely would go to, have some renal damage in the form of hypertension, proteinuria, again missed. Who takes the blood pressure of children unless they become symptomatic? So this is another thing that you follow a case of a first UTI and do simple things like growth monitoring, blood pressure, simple urine examination, and if required, a simple serum creatinine. And of course, unilateral urinary tract infection, pyelonephritis, can give rise to hypertension and proteinuria in adolescent. without being recognized. So non-recognition of the urinary tract infection, the first attack, definitely would lead to recurrent urinary tract infections.
So continuing with our case, child was started on cefixime as I mentioned earlier. By day 3, fever and pain had subsided, but pyuria had persisted. We had an ultrasound done which showed a right kidney having compensatory hypertrophy. Left kidney had irregular outline and increased echogenicity. Corticomedullary differentiation was normal. Cholestasis was slightly dilated, ureters were normal, and bladder showed normal thickness. I want to ask you, ma'am, what you already highlighted, but how we could have prevented this problem altogether?
Retrospectively, suppose the ultrasonography was done at the age of 6 years when first it was recognized. Probably, I'm not saying, there is no documentation of USG, probably we would have picked up this kind of a discrepancy between the two kidneys or some calyceal dilatation. And what is important, you must educate or you must give specific instructions to your ultrasonologist not to miss the bladder. Most of the time the kidneys are looked after, but most of the recommendation by the American Academy and also Indian Pediatric Nephrology Group, you should have what is called as RBUS, that means renal and bladder sonography. Because bladder sonography gives a lot of information about the thickness of the bladder wall, more than 3 millimeters, trabeculation of the bladder wall, ureterocele sometimes, and of course post-void residue, which is such a simple thing to diagnose, which can be responsible for the recurrent UTIs.
It's also because, ma'am, most of us write abdominal ultrasound, and without any history, the sonologist would not look at the bladder being a pelvic organ. So, any comments on imaging when, which, and how we should do to prevent a recurrent UTI, or in a case of recurrent UTI?
Actually, recommendations all over the world by the American Academy and NICE, as you know, the National Institute of Clinical Excellence, which is from UK, and Indian Society of Pediatric Nephrologists, every recurrent UTI must have a sonography minimum, because sonography, though gross, but it gives you some idea about any structural malformation, about the bladder, as I mentioned, and also post-void residue. Now, if the ultrasound is abnormal, then one should go ahead. But at the age of 10 years, in a boy, one should not do the MCU, which is a painful condition, and it is not really required. But one must follow down the line after 3 to 4 months with a DMSA renal scan. Why don't we do it right in the beginning? Because right in the beginning, the photopenic areas may show active infection, which is again documented. After 4 months, if you do have an abnormal DMSA scan, which I imagine in this child you would get in that kidney, left kidney, which was small, you should get some scars, and there was a pelvic calyceal dilatation. Under these circumstances, these children should undergo vigilance and a constant surveillance. And herein I would request the pediatrician to spend 5 minutes with the parents to tell them how vigilant they should be. That is important, rather than giving what is called long-term chemoprophylaxis, which is not recommended any more by the AAP and also ISPN. But in our country, I still believe we can be a little bit cautious, especially our parents are not very well educated. And I would give a chemoprophylaxis with small dose of cotrimoxazole or nitrofurantoin, at least for a period of 6 months to 1 year, and that's what we had recommended in this child when we send the patient back to the pediatrician. I think so far I had not still come on the scene of this patient.
Yeah, that's fine, that's absolutely okay. So now we are on day 10 of cefixime, and a repeat urine culture now shows E. coli trend, still shows E. coli trend to 6, now showing resistance to all cephalosporins and sensitive only to aminoglycoside. Counts were neutrophilic and BUN was 12. I wanted your comments on this 0.7 milligram creatinine and the concept of EGFR for us.
Right. Creatinine is a very, very easy to perform by all the labs, so it still is considered to be a good screening method for renal functions. But the accurate measurement of the kidney function is by the glomerular filtration rate. We no more need to do the 24 hours collection of urine and do the creatinine clearance. There is a simple bedside arithmetical method of estimating the glomerular filtration rate by a simple formula which has been worldwide accepted. It's called Schwartz method of GFR. That is, you do the plasma creatinine as in this particular child, and you take the height of the child in centimeters. Here I have not mentioned the EGFR because
I have not written the formula there.
Formula there. So
it's also to say for some of our lazy people, we have Android apps and iPhone apps which have met calculators. You can simply calculate on that as well.
And
how should
go ahead.
How should we go about treating this child further?
Yeah, this child, unfortunately, what had happened, one small little thing which we have missed, cefixime was continued for about 12 days without consulting the urine culture report, in which the cephalosporin resistance was already found, and there was only sensitivity to aminoglycoside.
Yeah. Today is 15th October, so that's the time when we got the second culture report, and that showed resistance to cephalosporin, as you rightly said.
This child would have been inappropriately or incompletely treated if he was not switched to the injection amikacin, which was at that stage. They called me, and we were this telephonic consultation I hate, but the patient came from very far off place, Mira Road or Nalasopara, and already admitted with the pediatrician, a very good pediatrician in whom I had faith that he will carry it out. And then he said, no madam, he still has tenderness. I want you to see at your consulting room at Namdevi. I said, send him over.
That's what we all do. Whenever we have problems, we refer our patients to you for all renal problems.
And hence he was put on injection amikacin. He did respond very well. And
you already made comments on antibiotic prophylaxis, but we want your final word. What should we do for our patients?
Antibiotic prophylaxis I think, should be a good idea to continue till you finish all the imaging studies, because you don't know what's going to happen in this particular child. Over a period of time, at least between 2 to 6 weeks, we recommend, by the time DMSA scan, or if required, if DMSA is required, as I said, 4 to 6 months. So in this particular child, since it was very vital to find out how much of damage is done to that kidney, which was actively infected, one would have continued the antibiotic prophylaxis for 6 months. In our situation, as I said, patients come from far off place. They don't have a proper comprehension about what is vigilance, what is surveillance, when to send the urine, when to suspect the UTI. It becomes difficult for us to just say, don't give any prophylaxis.
So broadly, if I want to categorize my patients with recurrent UTI into those with structural anomalies like VUR, PUJs, and those with voiding dysfunction and recurrent UTI, would there be a difference in giving antibiotic prophylaxis, or we would follow the same rule for both the groups?
No, I think there would be difference, because in voiding dysfunction and constipation, and for example circumcision, if you find a tight circumcision beyond the age of 2 years, we would first treat the probable cause which is causing a recurrence without any structural malformations. Structural malformations mean higher risk of damage which is permanent. Now about voiding dysfunction, a few points. Voiding dysfunction many a times due to faulty toilet training. Remember that. And if the toilet training is started by 2 years of age, and if the child is made to go to the bathroom in a relaxed manner and a complete voiding without running around, and if the mother takes a little voiding diary when the baby is sent to the school and the teacher says he or she wets the pants and I don't know, take care of, I think one could train the bladder at that particular time, condition the bladder to empty completely and periodically. But there are some children who have these problems like squatting and crossing the legs and all. There is nothing wrong. There is no meningomyelocele like a neurogenic bladder. There is no obstructed or a refluxing ureter. And these children benefit a lot by just simple things, by giving a small dose of sometimes oxybutynin. That means they can control the bladder capacity increases, the bladder is relaxed. So voiding problems should be dealt separately, whether there are any structural malformations or otherwise. And those don't require, in fact, if you give too many antibiotics, you produce a resistant strain of antibiotics. So also constipation.
As a pediatrician, you already mentioned, but if you can recap, how to do their follow-ups for all children with recurrent UTI, what all things we should be monitoring?
I think it is the mainstream children, how you follow, you should take it in that spirit. I'm sure you all do the height and weight, but specifically in the recurrent UTIs, we should do it very diligently. And if you do the height and if you have a creatinine, you write the GFR right away. So there is a basal at least, and the normal GFR, as you know, above 90. If it is above 90, then you're not worried. Blood pressure forms a very important role. As I said that, the after effects of the bilateral or unilateral scars are a hypertension. Early hypertension before the symptoms occur can be treated very, very effectively with not many drugs. The second important thing is a routine urine examination for the protein, not pus cells alone. Proteinuria is the first indication of nephropathy, as we say. That means something wrong with the kidney, especially bilateral scars. So you should document whether it is trace or 1+. Whenever suspected, you must get a urine routine and culture done before starting an antibiotic. Most of the time we are so much in a hurry, or the parents have already given amoxiclav or whatever, and you suppress the urine culture, and then you don't get a proper answer. And do make find out whether the your local lab or institution, what is their antibiotic policy, what is their susceptibility to E. coli, because E. coli forms 80% of UTI, and choose that antibiotic before even you have a culture report. And then you may change the antibiotic after getting the culture report. 10 to 14 days is a minimum treatment of acute pyelonephritis. So duration also should be. And this seems to be a very sort of a long and a formidable thing, but it is not so. If you counsel the parents, I think you will be able to recognize and prevent the next UTI. You have already missed the bus a little bit, but at least you will be able to.
Madam, I want your comments on the following. I want some of these words are used in association with recurrent UTI.
Yeah.
So I just want your comments. And there are a few more C's which are going to follow this.
Circumcision, as I mentioned, in a recurrent UTI, if you have not found any structural malformation, or you have found structural malformation, but it's a tight phimosis in a boy, because periurethral colonization is very important to prevent it by simple washing the preputial area with lot of water. And if that is not possible because of the tight phimosis, I think circumcision should be done. And there are any number of publications to say you can prevent the recurrent UTI if it is, but beyond 2 years we wouldn't like to do. Cranberry juice is, I think, overemphasized. Any liquid is important. I find some of the adolescents coming and asking, the boys say, we read on the net that the beer is very important. I said, no, it's not the beer, it's the liquid which is important. Some of the girls would say, can we drink Coca-Cola and this and that? Yeah, it is caffeine. After all, it will increase the urinary, sort of production.
Yes, that's one of the C's that's going to follow.
Yeah, oh, it is, you have got that also. Carbonated drinks.
So carbonated drinks and
Citrus
with or without
fruit,
caffeine, citrus fruits.
Citrus fruit, coconut water, soups, any liquid. The idea is to increase 1.5 times the liquid consumption so as to produce a good, urine output, and that also washes the urine and alkalinizes the urine. Though citrus fruit are considered to be acidic, but they have alkalinization of the urine effect. So that is one of the advantages. And cleaning after passing stool. Everybody knows, I hope that you teach the mothers how to clean the urinary parts, front to back, especially in a female child, and from front to back again towards the anal region. So never, sort of ask the mother or the caretaker to first, clean the stool or the perianal and then transfer it to the urine. So simple things are very important and play a role in preventing the urinary infection. Culture surveillance, I think I mentioned that fever without focus of infection about 100 degrees. And the mother should be told first to collect the urine appropriately, and that has been done in the last session. I think I won't go into. Before starting antibiotic, if the child is febrile, sick, vomiting, start the antibiotic, what is supposed to be acting in your hospital from the microbiology department. On day 3, you will get the culture report, and they take it from that whether to continue the same antibiotic or change, but duration should be minimum 12 days.
Thank you very much, madam. Sir, I would like to take your opinion for this second case. We have this 2-year-old child who was brought with history of fever for 4 days, had breathlessness and dry cough for last 2 days. On examination, he had tachypnea, was using his accessory muscles, though there was no cyanosis, murmur or clubbing. There was decreased air entry found on the left base and there was no associated wheeze. He also had history of 3 admissions with similar complaint, and last admission was only 2 weeks back. So can you give your clinical impression, then I would show the X-ray.
My clinical assessment, this patient has got infection because he has presented with fever. This infection probably of respiratory tract because he has presented with cough, increased work of respiration, even using accessory muscles, and there is absence of respiratory sounds, that is there is no wheeze, that means the respiratory tract is most probably not involved, and there is decreased air entry on the left base, so probably there is inflammatory region of the lung parenchyma on the left side on the basal region or left lower lobe. Past history of 3 admissions for similar complaints and last admission for 2 weeks. Possibility is either there is a recurrent pneumonia or resistant pneumonia or a deterioration, because in 2 weeks time twice he is admitted. So it may be deterioration of the original infective process, pneumonia going in empyema or something like that. So it may be recurrent,
Absolutely.
it may be resistant, it may be deterioration.
So he had brought his last X-ray with him and this is how it looked. I'm not sure whether you can appreciate this, so I have put these huge arrows. This was an X-ray done at the time of last admission. They don't have an X-ray at the time of discharge. This was 2 weeks back, and this is the X-ray done on day of admission. Both of them show left-sided
the 2 weeks
haziness
back he had
over here.
haziness at the left lower base. After 2 weeks also he has same picture. So more likely it is a resistant pneumonia rather than recurrent pneumonia, at least
as per
and
this
persistent pneumonia or recurrent pneumonia.
So
Now,
what do you think are the causes in
when
this
I say
case?
persistent, I mean the causes, either there is here the inappropriate antibiotic was used, or in inadequate doses, or less than optimum period for antibiotic was. These are the 3 reasons why there should be persistent infection of the lungs. If it is recurrent, by definition, there should be more than 2 pneumonias in 1 year period, or more than 3 in any given time of frame. And but provided in between the 2 attacks, patient was completely symptom free, and on X-ray there were no pulmonary, there is complete disappearance of pulmonary infiltrates, then one can say that this patient had a recurrent pneumonia. So in this patient, the 3 occasions he was admitted, I don't know the duration, at what interval he was admitted. So mostly it is either persistent or recurrent pneumonia. And
The parents
the
brought.
trend. I can't say recurrent, I can't
Yeah,
say
of
persistent
course,
unless
of
I
course.
like it.
So that's why we insisted, and by the time the patient got his her patient's previous X-rays, which were done at the age of 1 year, was showing this picture.
Yeah, these X-rays are showing some hazy shadow behind the heart.
Even on
in
lateral X-ray
plate
also
there
on
is
the
a hazy
left
shadow.
lateral also it's showing.
But there is no question of pneumonia as we got in the last X-ray.
Yes.
So probably there is some reason which is causing again and again infection. That's
Right.
only I can say. Either the developmental anomaly of the respiratory tract, or there is impacted foreign body, I don't know, or it's a endobronchial tuberculosis, I don't know. These are the different
So
possibilities.
that's what my next question was actually. What are the common causes that you would think of when you see a predisposing lesion in the same area where there has
So
been
when we
repeated
take
infections?
recurrent pneumonias, basically we have to divide the patients into 2 groups, where the pneumonia at the same site every time, the causes are different, as in this case. And as I told earlier, the 4 important causes are either impacted foreign body, or endobronchial tuberculosis, or any tumor which is pressing over the bronchus, causing the obstruction to the bronchus, causing stasis of respiratory secretions, which is a good media for a bacteria to grow, which trickles down and gives recurrent infection of the lower respiratory tract. And the most important group is the developmental anomaly of respiratory tract. It may be congenital cyst, it may be adenomatoid malformation, it may be sequestration. These are the different developmental anomalies. So some obstruction to the bronchus by the way of lymph node pressing, tumor pressing, in the bronchus, impacted foreign body, tuberculous endobronchitis, and developmental anomalies of
What investigation would you have asked next?
The investigations for these patients, number one, I will do tuberculin test, I will do CBC, ESR, gastric lavage, bronchoscopy for impacted foreign body,
yes,
and imaging.
So this is the imaging CT scan that we performed. As you rightly said,
left lower pneumonia with interlobar sequestration. There is a small cystic areas and
on the next image we can see the aorta and a direct.
Is the blood supply is from the artery arising from the descending aorta. It means this is not adenomatoid malformation. This is not cyst, but this is sequestration of the lung, non-functioning part of the lung due to lack of perfusion. So the best way is to do imaging with contrast, and also in this case particularly, if this is not available, I will also do ventilation perfusion scan.
Absolutely.
That differentiates between adenomatoid malformation and sequestration. There is no perfusion in sequestration, while adenomatoid malformation, the perfusion is normal, but the ventilation is poor. So this is the one can do.
What are the common organisms that we come across in, not only in this case, I'm saying in general when we have recurrent pneumonia?
Before going to common organisms, the other group of recurrent pneumonias, where you get pneumonias at different sites in the lungs, and the common causes are genetic causes like cystic fibrosis, immotile cilia syndrome, there may be aspiration syndromes, there may be immunodeficiency, primary immunodeficiency, secondary immunodeficiency. Patient might be having congenital heart disease with subclinical or clinical congestive heart failure, where aspirations are very commonly seen. So there are quite a number of different, and the organisms depends upon what is the basic etiological factor. If it is cystic fibrosis, it is the staph and Pseudomonas.
Yes.
If it is the aspiration syndromes, these are the gram-negative enterics which are responsible. If it's immunodeficiency, these are most opportunistic infections like pneumocystic carinae, cytomegalovirus, and so on. So it depends upon the basic etiology, it depends upon the age. For example, in impacted foreign body, if the child is below 4 years, the staph and strepto will be commonly seen. H. influenzae can be commonly seen. So it depends upon basic cause and the age of the patient.
So many times this so-called asthma or asthma-like situation as well as tuberculosis are mentioned as causes of recurrent pneumonia. Can you tell us in brief how do they come into picture?
We many times say that asthma causes recurrent pneumonias, but actually they are pseudo-pneumonias. Because of very thick secretions, there is blockage of the terminal bronchi, which causes atelectasis of the alveoli, and which is seen on the X-ray chest as pulmonary infiltrates. Most of the time these asthmatic attacks are caused by the viral infections, and so they present with fever. And many times they are on steroids. That's why if you do the blood examination, you will get polymorphonuclear leukocytosis. So fever, pulmonary infiltrates, and polymorphonuclear leukocytosis, we take it as pneumonia, but they are pseudopneumonia. They are not a real pneumonia. As far as tuberculosis is concerned, it is mainly lymph node pressing over the bronchus, causing the obstruction, causing the stasis, causing the growth of the bacteria, trickling down and getting secondary superadded infection. Same thing about tuberculosis, endobronchial tuberculosis.
Thank you, sir. So you've given us the message that any recurrent pneumonias you will define as 2 episodes in 1 year or at least 3 episodes. You must review all the old X-rays. you should differentiate between only LRTI or LRTI versus URTI. Try to focus on whether it's affecting the same area again and again or different areas, different types. And also look for extrapulmonary features as you would see. Thank you, sir. Dr. Gaurang, Narula, welcome. We'll start with your case right away because this clock is putting pressure on me. It's a 6-year-old boy diagnosed with ALL 3 months back. He has been started on chemotherapy and a port was introduced 1 month back. He is brought with history of fever, which was reported as 99.8 degrees Fahrenheit axillary temperature. One recording done today early morning. There were no other complaints. And the last CBC, which was done 3 days back, showed hemoglobin of 10.1, the total WBC count of 1,100 with 20% neutrophils, making an ANC of 220 only. And the platelets were 1,10,000. Now, should we say that this child has febrile neutropenia or not?
This child, does he have febrile neutropenia? Strictly speaking, if you want to go by the definition, we take a temperature of at least above 100 degrees Fahrenheit, clearly above 100, or it should be at around 100 for about 2 to 4 hours at least before we call it febrile neutropenia. So strictly speaking, he doesn't have febrile neutropenia. But this is a immunosuppressed child. He is a case of ALL. He is on chemotherapy, and he's also got a port. So in this situation, we would not like to ignore any symptoms of fever because this is an immunocompromised setting with a catheter. So there's a breach of skin. And
thank you very much. So that's what I wanted you to tell us, that it's not necessary to stick to the definition. If you find a sick child with neutropenia who is on chemotherapy, then you need to consider it as febrile neutropenia. On examination, this dilemma was solved because unfortunately child had 101.5 degrees when he landed with us. No other abnormalities were found. So Dr. Narula, how should we proceed now? This child with febrile neutropenia. What investigations we should send, and then we'll come to the treatment part.
So that earlier anomaly is settled. So now we are quite sure, since the temperature is clearly above 101 and above, that this is a case of febrile neutropenia. But for the sake of dealing with the case of febrile neutropenia, we tend to sort of categorize them into what is the risk over here. So there's a lot of data which is not there in this, so which I might have to presume. First of all, what is evident? What is evident is that this is a child who has got only fever and doesn't seem to be having any other systemic or localized features. And there's no other abnormality. He's otherwise well. From what I could see in his previous report, his HB and platelets are okay, so he's probably not severely myelosuppressed either. So if we take this as an uncomplicated case of febrile neutropenia, the fact that he's a case of ALL and he's got a port, and the ANC is below, there's some problem here? Yeah, and the ANC is well below 500, I would take this as a case of low-risk febrile neutropenia, except for the fact that he has a port. And we would send the blood cultures, and we would start him on empiric antibiotic therapy. If he had any localizing features like a cough or etc. or a loose motion, then accordingly we would send those cultures too.
So when you are categorizing them into low risk and high risk, there is some concept about anticipated low ANC for next 7 days versus not. So could you emphasize on that, please? Not related to this case, in general.
Yeah, so when somebody is expected to have profound neutropenia, or the neutropenic duration is expected to be longer than 7 days at least, this you calculate by knowing what kind of chemotherapy you have given and at what stage he has come after the chemotherapy and how suppressed he was before that particular chemotherapy was given. So it's an estimate. So you think that this neutropenia might last for a long duration. So those are the ones which we categorize as high risk. Of course, if there's any other systemic involvement, then again he immediately becomes high risk. I would take a patient with a port also as high risk, because we should not ignore the fact that he's got the port over there. Especially if the liver is involved or there's a renal compromise, then you should definitely consider it as high risk.
So how many blood cultures should we send? Should we send central lumen versus, suppose he has a central line, then should we send from each central lumen and a peripheral? And what is your normal practice and
So
recommendation?
we definitely send in the Tata Memorial, we send it from every lumen, depending on the number of lumens he has, and from the peripheral blood, because if there's a multiple lumen catheter, the chances that the infection may be seen, you may get a culture positive from only one lumen is as high as 30 to 40%. So if you take from one lumen only, you might very well miss the other one. So you should take from each lumen.
So when you mentioned about treatment, so can you give comments on monotherapy versus combination, empiric antifungal on first day, and use of aminoglycosides on first day? We are on day 0 right now.
Okay. So, well, I think every institute needs to develop its own, guidelines
Sure.
based on the kind of organisms which you are seeing. So we follow the principal policy of combination antibiotics. And that's because we get a lot of resistance. For some reason, the rates of ESBL, that's extended spectrum beta-lactamase organisms, and in fact, we are getting even a lot of multi-drug resistant organisms. So we are seeing a lot of carbapenem resistance now. So we go for combination chemotherapy.
So what combination, sorry to be interrupting you, but what combination would you do at Tata Memorial?
So what we are doing is we use a combination of cefuroxime, sulbactam, and an aminoglycoside upfront. So that's what we are doing. But if you want to take the recommendations, then even the IDCA guidelines now say that if you're using a 4th generation cephalosporin in combination or a carbapenem, you can use it as monotherapy. But I think this needs to be tempered by what your institutional experience is.
And an uncomplicated case, empiric antifungal may not have a role on day 0, or would you be?
So that would depend on the type of patient and your incidence of fungal infections. So like for our AMLs, we start on empiric antifungals in a prophylactic dose from day 1, day 0. In fact, even before they come in with fever, we started when we start the chemotherapy. An ALL who's had a fungal infection in the past, so like supposing he had fungal infection in induction, we would continue him on antifungal prophylactically right through his subsequent cycles till the fungal infection was been shown to have been cleared. In this particular patient, I guess we presuming that he's had no past history of a fungal infection and he's
no past history of fungal infection and not on prophylaxis.
So then he doesn't need an antifungal from day 0 at all.
So on day 2, the child was stable, but fever persisted, and we had blood cultures were not helping us in any way. X-ray chest, urine routine, cultures were and urine cultures were no growth. Stool routine was also normal. So what do we do now? Do we continue with the same antibiotics? We change, or we add anything on day 2?
Day 2 is
child is clinically stable and no fever, and fever continues.
So day 2, in the absence of any new developments, is very early to be changing the first line antibiotics. I don't see any reason to change at this stage.
We waited till day 4 and we got an ultrasound done. To our surprise, liver and spleen showed multiple abscesses which were thought to be fungal. And can you now help us about how to choose? No, it's a surprise, and we don't know why it came through.
So
that's why this case.
I would probably go back and say that this probably developed during the induction phase of chemotherapy, and may have been missed at that time because it can remain silent, and if the patient received empirical therapy at that time, it may have been a little suppressed. So if it is multiple abscesses in the spleen, then generally our experience has been that this is whenever we have aspirated it and cultured it also, we have seen that mostly it's Candida, but it's usually non-albicans. So that's the issue over here. For any invasive fungal disease, I think it's best to begin with amphotericin, which is the gold standard. But if you're asking us what we are doing, we are starting with voriconazole up front in these patients.
Suppose in this child would have improved, like many children who will come and they will have no fever on day 2, no focus, low risk, and no cultures grown. So how long do we continue the empiric antibiotics that we have started?
Again, policy is dictated by your own particular pressures, but we have a big stress on our beds. So we stop, and the data supports this. There have been enough studies now to show this. You can stop antibiotics if the patient has been febrile for 2 days, and you have an impression at least that the marrow might be recovering already.
ANC
so
is not a mandatory thing
no,
to wait.
it's not
because
mandatory at
as
all.
you said,
Yeah.
one of the recommendations would say that wait for ANC more than 500, which was a bother because many times because of the medication that is around, you may not have the ANC coming up in any.
So that's neither required, and that is, I think, also there's data now to support that it's really not required at all. If your count is rising, a lot of the neutrophils which are currently being seen as low may well be low because they're being consumed in the periphery, because neutrophils are very short-lived, as we know. So we don't strictly follow the ANC criteria. If you find that the ANC is rising and the patient is stable and he's been afebrile for about 48 hours, cultures are negative, there's really no need to continue antibiotics.
Can you tell us what common organisms that you see in a child with febrile neutropenia due to chemotherapy or on chemotherapy
So actually,
in your hospital?
Actually, according to me, the term febrile neutropenia is a misnomer, especially in the context of hematology. I think it's a hangover from the solid tumor oncology days. So there, when you give chemotherapy, there's myelosuppression and there's neutropenia, and that's where the experience started from. In hematological disorders, I think the more apt term is probably febrile immunosuppressia, if you pardon the coinage of the word, because all arms of the immune system are knocked down over here. So you have neutropenia, you have, because of your steroids and because of your intensive chemotherapy, even your lymphoid depletion is there. Your steroids will suppress antibody production. And if this has gone on for some time, like occurs in ALS and AMLs, then even your T cells are knocked out. So it's quite, you can get serious infections without any neutropenia. And we need to rethink this concept of febrile neutropenia. So our choices of antibiotics are often dictated by this.
Any specific key messages for us common pediatricians that office pediatricians?
I'm sorry, the main question was what organisms. So we are seeing a lot of ESBL and MDRO, gram-negative bacteria, and that's a key concern for us because it is not just patients who are being treated at Tata Memorial. These are patients who are coming in to us from outside when we do their screening cultures, which we are doing now because we have an epidemic of MDRO. We are finding a whole lot of patients who are already colonized with these bugs. So I think the key message is the rational use of antibiotics in the community, even before the patient comes to a tertiary center like Tata Memorial. That's the only way we can tackle this problem. Otherwise, I think we are well on the way of getting, Bombay is well on the way of getting its own metalloprotease, like New Delhi already has.
Thank you very much. Thank you all.